Good morning, good afternoon, and good evening, everyone, from wherever you're joining us, and welcome to our final webinar in the Neurophysiology 2023 series. Today's webinar is titled Updates in Chronic Traumatic Encephalopathy, or CTE, featuring Dr. Anne McKee, Professor of Neurology and Pathology and Director of Neuropathology Core at Boston University. Today, she'll present an update on her extensive research on the pathology of CTE. Just before we get started, we'd like to acknowledge our partners for this series, the American Physiological Society, the Federation of European Neuroscience Societies, the American Autonomic Society, Scientist.com, and in particular, the Society for Neuroscience as the host society for today's event. We'd also like to extend our sincere gratitude to the series sponsors, AD Instruments, Alzet, Diagnostic Biochips, Harvard Bioscience and Multichannel Systems, iPresio and PrimeTech, makers of the microinfusion pump, and Spark for helping to make this fantastic program possible. And now, without further ado, I'm very pleased to welcome our speaker, Dr. Anne McKee. Welcome, Anne. Thank you very much for joining us. Your slides are up, and please take it away whenever you're ready.
Okay, thank you. And thank you to the organizers and SFN for inviting me to this webinar. I'm delighted to share our work in chronic traumatic encephalopathy, and I'm going to try to present sort of an overview of the field in the last 16 to 20 years. So I always have to start out with this. I'm going to say a lot of things negative about football, but I was born right outside of Green Bay, Wisconsin, and just by virtue of my birth, I'm historically a huge Green Bay Packer fan. I come from a football family. Of course, my childhood was earmarked by Vince Lombardi and all the Green Bay Packers. This is my dad, who played football at Grinnell College in the 30s, my brothers who played for our local university, and this is me playing football at about age 2. So I come from a football family. I historically have loved football, and of course, my research has taken me in somewhat of a different direction. I'm going to talk about CTE today, and I'm also going to talk about its relationship to something known as repetitive head impacts. And this is where the real paradigm in science changed. 20 years ago, we thought of concussion and what we called mild traumatic brain injury as a very limited process that people easily recovered from. It wasn't considered a trigger for a neurodegenerative disease. But this work on CTE, my work and others, has shown that CTE, and I'm going to use the word caused, is caused by exposure to repetitive head impacts. And I think the data, the evidence for it being causal is overwhelming, and I'm going to present some of that today. These repetitive head impacts are most often experienced in contact sports, but they can also be military-related activities, domestic violence, etc. And of note, they don't just include what we call symptomatic concussions or what people notice. More importantly, repetitive impacts includes non-concussive injuries, which can be just as severe, just as high a magnitude as the concussive injuries, but don't produce symptoms. And over time, this exposure to these repetitive head impacts can be a trigger for CTE. So CTE was first described in 1928. It went by a different name called punch drunk. It was described by a pathologist who described the clinical syndrome that he said affected boxers who stayed in the ring too long. And then it was picked up in 1973, where Critchley and Carcelis and colleagues looked at a series of 15 boxers using silver stains. That was what the cutting edge of pathology in the 1970s, using silver stains, and they described the neuropathological alterations that were found in those 15 boxers. One very important report was in the early 1990s, and this was thioflavin. So now getting away from the silver stains, Hoff and colleagues described the findings of a very young woman, 24 years old, who was autistic and displayed self-injury behavior, head banging. And they found when she died that she had clusters of nerve fibrillary tangles around blood vessels, in her anterior temporal cortex. And this was really a shocking discovery. This is the first discovery of what I consider the hallmarks of CTE, this perivascular arrangement of nerve fibrillary tangles. And this was followed up at the end of the 1990s by a group in England who described 5 young men, 2 boxers, a rugby player, an epileptic, and a headbanger. And for the first time, they used tau immunocytochemistry. And they, too, described these clusters of tau immunoreactive tangles around small blood vessels at the crevices of the brain. Fast forward now to my first case, and that was in 2003. I work at the VA looking at veterans' brains, and one of the veterans that came into the brain bank, he came into the Alzheimer's disease brain bank because he had clinically suspected Alzheimer's disease. This was an autopsy that I did. This was my first experience with CTE. I had been extremely interested in tau pathology up until that time. And so when I looked at this brain with tau pathology, expecting to see Alzheimer's disease, I saw something extraordinary and clearly different than Alzheimer's. There was no A beta, and the tau pathology was doing something I'd never seen before. It was circling around small blood vessels in the brain. It was in the crevices of the brain along the blood vessels, and it was involving areas that are not affected in other tauopathies. This was the beginning of my interest. I wanted to see if this was something we could find in other boxers, and I started looking at other boxers. But then 2 years later, I saw this report about Mike Webster, who had been a former NFL player. This is a report by Amalo and colleagues out of Pittsburgh. And they described not only profound clinical alterations, but they described a tau pathology in the brain of this 50-year-old former football player. The pathology they described was not, they didn't describe that classic perivascular clustered pathology that I was looking for. So I wasn't sure if this represented the same thing, but that was, this was definitely something that was piquing my interest. And then, as luck would have it, or whatever that is, I happened to meet Chris Nowinski, who is a former professional wrestler, former Harvard football player, and Bob Cantu, who had been interested in concussion for a long time as a neurosurgeon. And they asked me if I'd be willing to look at the brains of former football players. And of course, this was a collision of not only personal interests, but also scientific interest. And these are my first 2 cases. They happened to be 2 former NFL players. They were both 45 at the time of their death. They both played in the NFL for 9 years. They both had some non-specific behavioral and mood symptoms, and they die at 45. And here are their brains in this middle section. And I was truly shocked to see this. Not only was I unaware as a football fan that this kind of thing could be happening to those players under the helmet, I was shocked to see this amount of pathology in such young men. And I should mention that in all of these cases, there was absolutely no beta amyloid. So there was no question about this being a tauopathy, and the nature and distribution of the pathology said it was this distinctive pathology of CTE. So right there, and then we started a brain bank. We wanted to investigate the long-term consequences of head trauma. And over the years, since the start, it's been extremely successful. We have over 1,450 brains at this point. You can see that we started out with just a trickle in the beginning, but then with the publication of papers and also the interest by the media, it has definitely enhanced our acquisition of brains. And most brains, almost all the brains, come in because of a call to our pager and our 24-hour cell phone by interested families. So most of them come in from families who want to know if their loved one had CTE. At this point, I'm just giving you a snapshot of the brain bank. It's mostly men. Of course, we're extremely interested in getting more female donations. Football is highly represented. It's our most common background for how they experienced head injury. And most of our brain donors are white, about 13.5 are Black. We need to understand this disease in underrepresented groups. So these are things that we're trying to do for the future. And this is the pathognomonic lesion of CTE. This is the lesion that defines CTE at autopsy. It's a lesion that consists of tau in nerve cells with or without glial tau, and it's around a small blood vessel, and it is characteristically at the depths of the cortical sulci. And this is the lesion that defines the disease. If you see this lesion, even one lesion, that is, you can make this diagnosis. So just again, the hallmarks of this disease are the perivascular nature. It hugs small blood vessels, and it deposits in the crevices of the brain preferentially. We also described a staging scheme of pathologic severity back in 2013. We divided the pathology into 4 stages, where 1 is the most mild and stage 4 is the most severe. We saw that there was a significant correlation with age at death. That is, the young brain donors usually had the milder stage 1, stage 2 disease, and the older players often had more severe stage 3, stage 4. And even in this early report, we found a dose response. That is, the CTE stage correlated with the number of years they played football. The longer they played, the higher the CTE stage. And that is something we've seen over and over in more recent studies. With the second consensus conference, they established 2 things, or many things. They confirmed the pathognomonic lesion. They confirmed that the initial injury is neuronal. It's not a glial tau pathology. And they, when only a limited number of slides are available, they classified CTE into mild and severe pathology, which correlates pretty closely to what our stages of CTE. So low would be stage 1 and 2, as depicted here. Low stage CTE is a cortical pathology. You see these epicenters or foci in the cortex, usually at the depths of the sulcus, but you don't see widespread pathology. In the high stage, stages 3 and 4, you start to see expansion of the cortical pathology extending into widespread regions of the cortex. And notably, you start to see involvement of the medial temporal lobe, the amygdala, the hippocampus, the entorhinal cortex. These are the main distinctions between low and high, or mild and severe CTE. We did a study subsequently, Michael Lasko and myself, where we looked at quantitative tau pathology, both semi-quantitative and quantitative digital assessments. And we found that the staging scheme, the McKee, what we call now the McKee staging scheme, associated quite nicely with quantitative assessment of tau in multiple brain regions. We confirmed that it also associates with age of death. And importantly, we determined that it correlates with dementia status. And we've seen that over and over now, that the degree of tau pathology correlates with dementia in these individuals. It also correlates, again, with years of football play, which we use as a proxy for cumulative RHI exposure. Now, I'm not going to get too much into the symptoms of CTE today, because there's so much to cover with the pathology. But I'm sure you're aware that there's dementia and cognitive impairment, especially in the late stages of CTE. So that is something we see in the older individuals with stage 3 and 4. But in the younger individuals, and often very prominently, we see behavioral mood changes, psychiatric changes. We see explosivity, we see loss of control, we see impulsivity, we see rage behaviors, depression, hopelessness. And often the person is aware that they can't control their brain. And these symptoms, these behavioral mood symptoms, have been less well correlated with the tau pathology. In fact, we're only starting to see some of these as correlating with the tau pathology. We think there might be a different pathological underpinning for some of these more behavioral and mood symptoms. Now, our research was definitely enhanced in this 2019 paper by Benjamin Falcon and Michel Goddard and others, where they described a unique CTE fold ultrastructurally using cryo-EM, where they described a hydrophobic molecule at the center of the CTE fold that was distinct from Alzheimer's and distinct from any other tauopathy. And this helped establish that CTE is indeed a unique pathology that is not shared with Alzheimer's disease or these other tauopathies. John Cherry, an associate professor in our lab, and Morgan Butler, doctoral students in the lab, have really looked at the tau isoforms in CTE. We know that it's a mixed 3R and 4R tau, and their work also showed that in early CTE, stage 1 and 2, it tends to be 4R tau that predominates. As the disease becomes more severe and you get into 3 and 4R tau in the older individuals, you see a shift towards the 3R being more prevalent. 4R tau is in astrocytes, but the astrocytes are seen with age. They're not found in the younger individuals, and they're found especially after 60, age 60. And astrocytic tau appears to be exclusively 4R tau. Now, I'm going to look at the evidence for why is RHI causal? How does head injury, small impacts to the brain, cause tau to be deposited in those regions? And one of the reasons we think it's true is because the physics of the injury, these acceleration, deceleration, rotational injuries cause the greatest stretch of the brain tissue, the greatest distortion of the tissue at the crevices of the brain. They see disproportionately more movement, and we also see disproportionately more tissue displacement at the interface of two tissues, a different elastic properties like blood vessels and brain parenchyma. So we think that's the reason tau is deposited in those regions. And there have been multiple studies now done internationally using computational models, finite element models, and they show convincingly that the greatest tissue strain and deformation in these impact injuries occurs at the depths of the sulci in the cortex and in the perivascular region. Another piece of evidence is studies in muskoxen. We don't have a great rodent model of CTE, and partially that's because they're not gyroencephalic. They don't have the structure that humans have. They don't have nearly the amount of white matter, and certainly they don't have a gyri. But studies in muskoxen, and this was done by Patrick Hoff and Nicole Ackerman, and they showed that in these muskoxen who participate in headbutting, if you look at their brains after death, they do get a tau pathology, and that tau pathology tends to occur at the sulcal depths and occasionally around blood vessels, and it mimics, in some ways, the tau pathology of CTE. Now, this is one of our most infamous publications. This is a report in JAMA that was picked up by the New York Times. This is where we reported our experience as a brain bank with American football players. And at the time, we had 202 American football players, and we reported the CTE and the clinical findings in that series. And what we found was in this brain bank series, we had a very high percentage of former NFL players who were diagnosed with CTE. In fact, it was 110 out of 111, 99%. Now, this is a brain bank study. It has lots of selection bias. We tried to make that clear in the publication. It does not represent the percentage of former NFL athletes who have this disease. But in this very special case series that the brain donors, we find a high percentage of CTE in the NFL players, also in former college players, and even about 20% in high school players. After the paper came out, Biney and Bashinsky estimated the prevalence of CTE at death among all the professional football players who had died during that study period. And if you assume that we got all those NFL players that had CTE, that no one died somewhere else and didn't donate their brain, the lowest possible prevalence of CTE amongst NFL players is around 10%, 9.6%. But if you make the much more likely assumption that we only got 10 or 20% of those football players with CTE, then the prevalence in the NFL rises to something more like 80% or even higher. I'm going to show you one of these cases just to show you how the brain bank operates. Many of you are familiar with the story of Aaron Hernandez, only 27 when he died. Here's the brain bank. The brain comes in. This is my colleague, Victor Alvarez. We look at the brain grossly. We take sections after weighing and carefully photographing the brain. And in Aaron Hernandez's case, the brain was heavy. It weighed a lot, but these NFL players are big people, and often we see quite heavy brain weights. On external surface, this brain looks normal to me. It looks absolutely unremarkable. But when we did the coronal sections, we could start to see changes. He had tremendous ventricular enlargement compared to what we would expect in a 27-year-old. And he had a lot of atrophy of the fornix. Not only that, but he had perforations of the fornix, which is something I'd never seen in an individual under the age of 45. And then microscopically, the classic pathology of CTE, the tau in nerve cells as nerve fibrillary tangles and these neurites, many of them dot-like, around small blood vessels. And if you laid out coronal sections of his cerebral cortex, you can see that he had really profound involvement of his frontal lobes, really almost half of his frontal lobe involved with tau pathology, and it was classic CTE in Aaron Hernandez. So the brain bank population, seeing over 99% in former NFL players, is skewed by selection bias. But I just want to compare it to what we see in unselected brain banks and community brain banks. This was work done internationally after that paper that came out in JAMA. And individuals have looked for CTE in community brain banks, unselected brain banks, and the incidence of CTE is quite rare. It runs from 0 to 2.2%. So that makes the percentage of CTE that we see in these brain banks with a selection bias seem more impressive. I want to show you a case that was described just this summer. It was described in Australia by Michael Buckland and Catherine Suter. And this is the first female athlete that's ever been described with CTE. She was 28 years old. She'd played she had a long career in Australian rules football. She was a professional football player. She also served in the military and martial arts, and she developed CTE, and the case they described is an absolutely beautiful demonstration of low-stage CTE with these isolated cortical sulci at the depths of the sulcus in this young woman. So back to the evidence for RHI causing CTE. We've done more work on the dose-response relationship. This is a report from Jesse Mez, Dan Danshavar, and others using, again, our Unite Brain Bank. And they used simulation and inverse probability weighting, accounted for all degrees of selection bias. And they found that there was a dose relationship between the number of years of football played and the risk for developing CTE, as well as the risk for developing severe CTE. I'm sorry, they keep jumping ahead. But importantly, they found that the risk of developing CTE rose by about 30% per year of football played, or in other words, for each additional 2.6 years of football, the odds of developing CTE double. They also showed that the odds for developing severe CTE were enhanced as well, and that there were some seeming cut points in that people that played less than 4.5 years were 10 times less likely to develop CTE than someone who played longer. And if an individual played 14.5 years of football, they were 10 times more likely to develop CTE than someone who played less. And then this summer, this is Dan Danchevar described that it isn't just the number of hits. It's not just the cumulative number of head impacts. It's also the strength of the impacts, the severity, the magnitude of the impacts that gives rise to risk for CTE. And this is a paper in Nature Communications showing cumulative hits, but also players who get high hits, heavy hits, severe hits, like defensive backs and wide receivers, are also increased in their susceptibility towards CTE. And then if you look at the literature, well, how many cases of CTE have been described in the literature since in the recent years? I'm not going back to the old literature before 2003. But if you look at the cases of CTE reported in the last 20 years, it's 639 cases of CTE. And if you read those reports, 622 of those cases, over 97%, there was an association in the case with RHI exposure, contact sports, poorly controlled epilepsy, domestic violence, military service. Overwhelmingly, the individuals with CTE had experienced repetitive head impacts. There are 17 cases where the history of CTE was not obtained, so we just don't know if they had head impacts. And in only 4, about 0.6%, was there no history of RHI. So overwhelmingly, it appears that RHI is a cause of CTE, and there's no other common denominator that has thus far been reported. So what are the other changes that occur in the brain besides tau pathology and CTE? Well, inflammation. And inflammation increases immediately after hits to the head, and it continues to rise as an individual develops CTE. This is a paper that was done by John Cherry, again, showing a significant increase in microglial inflammation after head hits, and that inflammation increases steadily with the severity of CTE. Importantly, he also showed a dose-response relationship. Years of exposure of football increased inflammation. Years of exposure to football also increased tau pathology. And he described a trauma-independent vicious cycle where inflammation produces more tau pathology, and tau pathology creates more inflammation. So after triggering the disease through trauma, you can develop a trauma-independent cascade where tau pathology and inflammation steadily increase each other. What's the evidence for inflammation in CTE? There's been many reports, and I'm not going to go through these in detail, but differential cytokines are increased in CTE, like CCL11, CCL2. We know that neuroimmune proteins, different cytokines, differentiate between AD and PSP and other tauopathies in CTE. We know that there's differential vulnerability for CTE depending on inheritance of the TMEM106B allele, a relative resilience gene, and also a gene that governs inflammation. We know there's differential gene expression in the crest of the cortical sulcus compared to the sulcus, and we know that inflammation and neuronal gene expression differ in the early or mild CTE compared to the late or more severe CTE. So there's lots of lines of evidence suggesting inflammation is clearly involved in CTE. We also know there are microvascular changes, changes to the small blood vessels. And this was originally reported back in the 90s, again, by Patrick Hoff and other, I think they were from Vienna, showing alterations in the cerebral microvasculature in dementia pugilistica. And then this blood-brain barrier dysfunction was described by Colin Doherty and Matthew Campbell, Irish collaborators looking at the blood-brain barrier. And we've recently described vascular injury markers being increased after RHI and CTE in our brain bank. And this is work done by my doctoral student who just passed his thesis, Daniel Kirsch, and this is a report from last summer in GANEN, where he showed increased in vascular injury markers in CTE and RHI. And then this is work of another postdoc in Russ Huber's lab, using clarity or the ability to, make the brain translucent, showing increased vascular density and branching in CTE and after RHI. And this was Grace Rosen reporting in Acta Neuropathologica. Astrocytes are also all altered after RHI and in CTE. The original report of this, called interface astroglial scarring, was after blast injury, and that was described by Dan Pearl and colleagues. Subsequently, last year, Katie Babcock, another doctoral student in the lab, described this very characteristic interface astrogliosis, not just after blast, but also after impact injury, after RHI, and again in CTE. So an alterations of astrocytes also occurs after head injury and in CTE. This is a work of another graduate student, Sarah Chancellor, who looked using single-nuc-seq at oligodendrocytes and found that in CTE, oligodendrocytes are decreased and they're altered in their subtypes. They show increased transcripts relevant to iron metabolism and cell stress. And we know that iron is also increased in CTE histologically. So more evidence of a different type of damage in CTE, in this case, oligodendrocytes being lost. White matter loss in CTE has been reported. This is Michael Lasko looking at white matter loss, or what we call white matter rarefaction at pathology, and finding that white matter loss in CTE correlates with the tau pathology. It correlates with years of play. And importantly, it also correlates with the dementia, the clinical symptom of dementia. This is a study from Tor Steen looking at myelin proteins in RHI and CTE, and this is finding decreased myelin in these football-related RHI and CTE. And in this case, he's showing a relationship between some of the non-cognitive symptoms, functional impairment, and I think importantly, impulsivity. So the first evidence that maybe these white matter changes, myelin changes, might lead to increased impulsivity in individuals. And then this is an antemortem flare white matter study looking at brain donors who happen to have an MRI prior to death. And this, again, is Michael Lasko and Madeline Uretsky. And they're finding that these white matter hyperintensities, their total lesion volume on these flares, was correlated with the pathology. It was correlated with white matter loss on pathology, CTE stage on pathology, and also the amount of tau pathology on postmortem exam. So white matter changes, vascular injury, inflammation. What other proteins are deposited in CTE? TDP43 is one. And this was reported about 14 years ago. We reported ALS in association with CTE. This occurs in about 5 or 6% of individuals with CTE. And it's also been described that former NFL players are at increased risk for developing ALS and dying from ALS. And this was reported first by Lehman in neurology in 2012, and more recently by Dan Danchavar in JAMA Open, where their former NFL athletes had over a 5-time increase in risk for CTE compared to the general age-matched population. A more recent study shows that hippocampal sclerosis is differentially or increased in CTE. And when it's found in CTE, it's associated with TDP-43 pathology. Now, there have been some case reports that were reported over the last decade by several groups, Leah Grinberg in San Francisco, and a Dutch group showing case reports of CTE with hippocampal sclerosis and TDP-43 pathology. And then this was a study done by Ray Nix and Torstein out of our group, where they looked at how many of our CTE cases had hippocampal sclerosis. It's about 23%. And in those cases with hippocampal sclerosis, how many had TDP-43 pathology? And it was almost all of them. It was 95.7%. So in more severe CTE, TDP-43 pathology is common and often in association with hippocampal sclerosis. And then looking more, into these individuals with CTE and high hippocampal sclerosis, Tor found that they tended to be younger. Those who developed hippocampal sclerosis and TDP were younger than those without hippocampal sclerosis, and those that developed hippocampal sclerosis had more greater RHI exposure compared to those who had developed CTE without hippocampal sclerosis. So another dose response for risk of hippocampal sclerosis. What other neurodegenerative proteins accumulate after RHI and CTE? Alpha-synuclein, this is a report in Journal of Neurology, Experimental Neuropathology by Torstein and Jason Adams. And this particular paper shows that Lewy bodies are increased in individuals who've had cumulative RHI. This was a study using the Framingham Heart Study subjects, showing that after, I believe it was 8 years of contact sport at any level, they had increased risk for developing Lewy body disease. And then we've also seen in previous reports by Tor again, and that beta amyloid the deposition of beta amyloid in CTE is accelerated. It occurs at a younger age, and it deposits at an accelerated rate compared to normal aging. And this is another recent report by Torstein and Nicole Saltiel showing that dementia after RHI can be caused by multiple pathology. And we've talked about CTE and CTE's relationship to dementia, but often once these individuals develop CTE, the neurodegenerative pathologies start to pile on. And there is some synergistic relationship between these multiple pathologies. And those pathologies include TDP-43, congophilic amyloid angiopathy, Alzheimer's disease, as I mentioned before, hippocampal sclerosis, and Lewy body disease. In Tor's paper, they observed 252 unique combinations between these pathologies, and that was lower than you would expect if all these pathologies were independent. So there is some synergistic risk for these multiple pathologies. These pathologies are interrelated. And then I'm going to end up with this study that we reported at the end of August of this year. To me, this was a very important study because what we did in this study was look at the young athletes, the individuals who had not reached the age of 30 before becoming brain donors, coming into our brain bank. And I thought the importance of this study was several-fold. That first, they didn't have other pathologies. They were too young to have developed comorbidities. So we were going to be looking at the earliest manifestations of disease before the effects of aging really start to play into the evolution or pathogenesis. And, I wanted to look at the nature of the lesions and were there any other associated findings. And in this report, again, this is a brain donor, this is 150 contact sport athletes who were donated to our brain bank under the age of 30. We looked at all of them for CTE, and we found about 40%, about 63 had CTE at autopsy. Now, most of the time it was early CTE, stage 1, stage 2, but we still, it was still, I think, a remarkable finding. Most of these individuals were men, and most of them played sports, contact sport. They all played contact sports. Most of them played amateur sports, and that included American football, ice hockey, soccer, rugby, and wrestling. There was one woman, so this is the first American woman with CTE that played amateur soccer. She played collegiate soccer. Notably, the brain donors with CTE were about 4 years older than those who didn't have CTE, and those who developed CTE played significantly longer, about, again, three years longer than those who didn't develop CTE. This is just showing you the table of these statistics, the early pathology that we're seeing in these cases, that focal cortical pathology, which was sometimes quite substantial. And then, this again is the brain of Aaron Hernandez, showing you that some appeared to have early spread into distant regions of the brain, early involvement of the medial temporal lobe, and were described as stage 3 CTE. We did find that some of the individuals with CTE had macroscopic brain changes, or changes that we could see with our naked eye, and that includes cavum septum pellucidum. So it's not a specific change to CTE. It can be found at birth, but we did find a significantly high number of those with CTE had cavum septum pellucidum. We also found that there was evidence of a dilatation of the frontal horns of the lateral ventricles, an indication that there's mild cerebral atrophy in these individuals. So that was significantly increased. And there was also a thalamic notch, indicating potentially some thalamic atrophy in these individuals who had CTE. I'm just going to show you what these look like in these coronal slabs. That's cavum septum pellucidum. That's dilatation of the lateral ventricles, and that's what a thalamic notch looks like, or dilatation of the third ventricle. And then you can see these different variations down below. What does the lesion look like in these young athletes? They're beautiful, discrete lesions. They're characterized by tau abnormalities and neurofibrillary tangles. And you can see this very prominent dot-like appearance of the neurites in early CTE, and that is a consistent finding. And again, I've stressed it before, there's no tau in astrocytes, there's no R-tag in these individuals. It's a purely neuronal injury. And this, again, using multiplex immunofluorescence, is showing that the tau pathology co-localizes with the neuronal marker MAP2 and not with the astrocytic marker GFAP. We also found there were other microscopic abnormalities that were increased in the individuals with CTE. White matter loss, white matter rarefaction was not quite significant, but it trended to be increased in those with CTE. And there was a significant increase in the amount of perivascular macrophages in the white matter. So not in the CTE lesion, but in the white matter, we saw pigmented macrophages around the small blood vessels, which we interpret as breach of the blood-brain barrier with leakage of toxins and blood outside the vascular space. And this is what those perivascular macrophages look like. You can see they can be quite numerous. Remember, these are individuals who are in their 20s. These are not aged individuals. There can be very prominent perivascular macrophage deposition. There's lots of inflammation, as seen here with IBA1. And there's also white matter rarefaction or degeneration, even in these young people. We found that years of play, the longer their exposure to RHI, was associated with this perivascular macrophage change, just that it was highly significant. Interestingly, when we looked at the clinical scales, the clinical features that we were able to ascertain in these brain donors, we did not see any cognitive, behavioral, or mood symptoms that were different between the CTE and non-CTE folks. They were highly frequent in both those with CTE and those without CTE. And there's several possible explanations for this. I think the two most likely explanations are, A, these are retrospective interviews. We're asking the next of kin, their parents, their spouse, what the clinical symptoms were, what they were experiencing. It's not as granular, it's not as precise as it would have been had we been able to look at these individuals during life and test them, do neuropsych exams, neurology exams, talk to them directly. So our methods are somewhat limited in this is a retrospective review, and we might have missed some detailed changes in this kind of method. But the other thing is, I think, and this is, I think that it's likely that symptoms, behavioral, mood, psychiatric symptoms might be increased just after RHI, even before the development of tau pathology. And that's something we're going to have to work out in the future with individuals coming into the clinic and being evaluated in life. But there's more and more evidence that just exposure to head hits themselves before the development of CTE can also produce symptoms. So to summarize what I'm trying to get at, and this is somewhat slightly speculative, some of it's based on our data and the data that's out there, this is how I would put it together. That inflammation is one of the earliest changes. It occurs in RHI, and it increases with exposure to RHI, and it steadily increases with the development of CTE. Vascular permeability is tightly linked. The injury to the small blood vessels, especially in the white matter, is tightly linked to this inflammation with the release of neurotoxins, cytotoxins, different cytokines. It's associated with white matter loss, and we see oligodendrocyte loss, we see loss of myelin proteins, and we see white matter changes on flare, and on pathology. So white matter loss, not only in CTE, which gradually gets worse, but these changes develop before the onset of CTE. And I think we're going to see that neurobehavioral symptoms reflect or parallel these non-tau pathologies that we see after RHI, before the development of tau. Tau pathology comes on a bit later. Early, it's very minimal in CTE 1 and 2, but then with aging, there's a huge increase between CTE 2 and CTE 3, where the tau pathology becomes widespread. It spreads in the cortex, it spreads to the medial temporal lobe, and it spreads to the brain stem and beyond. And in this spreading pathology, the non-cortical pathology, this is no longer perivascular. The initial pathology is perivascular and cortical, but this spreading pathology is diffuse and involves widespread regions of the brain and even the spinal cord. That's when you see brain atrophy. You also see cognitive decline, and you can see in these late stages the deposition of TDP-43. Most of the time, it's in these later stages. And in about 24%, these individuals develop hippocampal sclerosis. Functional decline comes late. This is a disease that develops over decades. They are often injured in their 20s and early 30s, and they become symptomatic later, often in their 40s and 50s. So functional decline probably reflects the plasticity of the nervous system, their ability to develop resilience and compensatory mechanisms for the pathology. And so many of these individuals don't develop dependence on others for activities of daily living until very late in the disease. And then there is a subset, about 5 or 6%, that develop TDP-43 deposition early and go on to be diagnosed with ALS. So to put this in a slightly different way, I think these are the acute changes, probably progressive, or I should say sometimes progressive. We don't really have all the data on whether or not these early changes progress, even if a person gives up the sport or the activity. But these early changes are inflammation, vascular injury with blood-brain barrier breach, axonal loss, myelin loss, oligodendrocyte loss, white matter degeneration, and interface astrogliosis. And we see these before the onset of tau deposition. They tend to get worse with CTE. CTE develops, it's a chronic pathology, it's progressive, it increases steadily with age, and ultimately TDP-43 is deposited in many of these individuals. And then the multiple neurodegenerative pathologies tend to pile on, and those can be Alzheimer's disease, Lewy body disease, hippocampal sclerosis, and ALS. CTE is not just a problem for football players. It occurs in rugby, soccer, ice hockey, military veterans as well. These are all subjects of another talk. There are some genetic modifiers. ApoE4 increases CTE severity in the tau pathology. It isn't a risk for CTE per se. TMEM106 is associated with less tau, less inflammation, and reduced odds for dementia. Age is associated with worse CTE. A high occupational attainment predicts later cognitive impairment. We know that millions of people are at risk for CTE. Many of these contact sports are played worldwide. The solution is prevention, reducing how many times, how hard athletes are hit in the head. This can be done many ways, but here are some of them: reducing heading, number of games, shorten games, reduce the age at which head impacts are introduced. And I think we should start monitoring these players. How many times, how hard have they been hit in the head in a single season? We need a diagnosis during life. If we had a diagnosis in life, we could start to try many of the potential treatments that are out there. We're looking at fluid biomarkers, and there's a whole, multiple markers that are being looked after. It probably will be several markers together that are specific for CTE. And we're looking at neuroimaging, primarily tau PET imaging, looking at ways to diagnose CTE in life. We're using tau ligands that were developed in Alzheimer's disease. So we're working on developing new ligands that are more specific for CTE tau, and that is ongoing at multiple centers. I want to thank all the families that donated their loved ones' brains, who couldn't do any of this without them and their participation in all our studies. I want to thank our funding sources, the VA, NIH, Nick and Lynn Bonaconti, the Tau Consortium, the Andlinger Foundation, the WWE, the NFL, NOXI, and I want to thank my team. We have a huge team now to do this work. They're all extremely committed, and I'm honored to work with all of them. And that's it.
Dr. McKee, okay, wonderful. Thank you so much. That was quite incredible. We've got quite a large number of questions coming in. Maybe one to start with. I think this question was asked before, but maybe just for clarity, the question was about which regions of the brain are affected in RHI and CTE. And am I correct that you're saying the suspicion is that it's a mechanical susceptibility due to the tissue interface rather than any other different cell type or any other anatomical features?
Yeah, I mean, the evidence suggests it's mechanical. It's the physics of the injury, and nerve cells are preferentially involved, especially as they hug the back, as they surround blood vessels. We know there's probably a differential reaction to the physics. So if the blood vessel reacting differently than the brain parenchyma, there's more stretch, there's more distortion. So yeah, I do think this is, believe it or not, a mechanical injury.
Okay, but remarkable. Is there any apparent susceptibility to certain cell types within those regions, for example, within the sulci, that makes them more vulnerable to damage and deposits?
Yeah, I mean, I don't think we have the answer for that at this point. I know we're working on it, which layers appear to be preferentially involved, if, excitatory neurons, et cetera, but those are actually, we're still working on that. So we know it's nerve cells, but is it a specific class of nerve cells? We're not there yet.
Okay. If there are microvascular alterations due to CTE, why are we unable to effectively diagnose them with, say, fMRI at the moment?
fMRI, well, we do see changes with fMRI. I think at this point, though, we're just not able to see changes that are specific to CTE. There's just so much, there's a non-specificity to the response, and it just needs to be more granular, or just so that it can be, I don't do functional MRI, so I can't tell you everything, but sure. I can just say that, there are clearly changes in individuals after a single season of these sports. But at this point, they're not specific to CTE tau pathology.
Got it. So basically, you can see differences, but attributing those differences to CTE specifically is a higher bar, I suppose, right? You mentioned animal models and the oxen. It's incredible stuff there. Are there any animal models in development, or anything that at all approximates? I know you said there weren't any good ones at the moment.
Well, I think there are problems with everyone, and I don't want to. I think that rodent models are going to be great for mild TBI. It's a different injury. It doesn't have all the parallels to the human brain. And since we're talking about this mainly being a mechanical problem, the mechanics of the brain are going to play a big role in the nature of the pathology. So we definitely have rodent models of mild TBI, repetitive mild TBI, that we can gain a lot of information from in terms of inflammation. Not all of them produce tau pathology, but some do. So, we can learn a lot from those studies. I shouldn't have just made that blatant statement, but it is difficult when you've got a mechanical injury producing a pathology to use a lissencephalic animal. There are studies in miniature pigs. There are studies in, I think, other mammals. I think ferrets, I've heard, but I don't know where we are with those, and sure. I'm sure other people can address that more clearly.
I guess there's a difference between mimicking an element of a pathology and the entire pathology as well.
Right.
Are CTE stages correlated with Braak stages?
Braak stages, well, I don't understand. Braak stages are used in Alzheimer's disease, and so it is related to the severity and density of the tau pathology. Braak stage, though, is specific for Alzheimer's disease tau. And Alzheimer's disease pathology is in different laminae. It occurs in layer 3 and 5, whereas CTE pathology is a superficial predominance. So you can't, the Braak stages are not the same as CTE stages.
Okay. Not entirely independent, but not the same thing, I guess.
Right.
You mentioned demyelination and astrocytic scarring found in donor tissues, suggesting neuroinflammatory activation upon repetitive head injury. Do you expect microglial activation contributes, as we see with many other degenerative pathologies? I think you touched on that already. But there was another related question with the scar. Is the scar similar, the astroglial scar, similar to what you'd see in other traumas?
Well, it's similar to what has been reported in blast neurotrauma. We've seen it in blast neurotrauma. I haven't looked at severe TBI, moderate severe TBI, so I can't tell you there. But I do think it's a nonspecific reaction to mild repetitive injury. I think, it's not, I think it's a generalized response of the brain. So I wouldn't be surprised if it's found after different types of TBI.
Question here about the connections with Alzheimer's. It's often assumed that beta amyloid plaques lead to tauopathy. Do the CTE data an increased risk of other neurodegenerative disease suggest that tau can predispose the brain to deposit beta amyloid and other clumping proteins like alpha-synuclein?
Yeah, I think that's an interesting thought. I don't know if that study's been done, but there definitely is a synergistic relationship between that we, in our studies between tau and the development of other proteinopathies. Certainly for TDP-43, which co-localize in many of the cases, you can see the TDP-43 depositing in those same perivascular depths of sulcus areas. That's not seen in FTLD TDP-43, so that's unique to CTE. And then, I think it's likely that there's an interaction with other neurodegenerative proteins like A beta, like alpha-synuclein.
Okay, fantastic. A couple questions here in relation to age. Is there any research been done on the age at which one experiences repetitive head injury or concussions, on the susceptibility to developing a CTE? For example, another question cites repeated falls at daycare, for example, or anything of that nature.
Yeah, well, we don't really have any experience with children and those falls in daycare and out of their bed, and toddlers fall all the time. I doubt those injuries are of the magnitude that is experienced by these other individuals. These are 100G injuries. They're really quite large injuries to the brain, magnitude that's occurring there. People have equated them to a car being driven at 35 miles per hour being driven into a wall. So these are substantial injuries. Toddlers are short. They don't fall that far when they get injured. But we haven't done anything on pediatrics. I can tell you we're looking at age of first exposure, when these people start to play these sports. Some of these football players start at 5. Is that altering the pathology? And so far, we don't have that. We don't have that they have altered pathology. Our only data so far suggests that they are clinically more susceptible. They're more susceptible to early symptoms. The symptoms come on earlier if they start earlier, but we don't have a pathologic differential with early starts.
Okay, is there a gender difference as well in terms of susceptibility? We had a couple questions related to that.
Yeah, gender is hugely important. We're seeing in concussion and athlete injury that women are more susceptible and have a longer recovery time. I think there's some experimental evidence of differences between genders. Unfortunately, we only have 4 to 5% women, and it's just not enough to make any statements. But I think it's incredibly important, and a push for getting more female to consider donating their brains. Is always that's the stumbling block here, is getting brain donations.
Right. There are a couple questions. Is there anything that so obviously prevention is a major thing. Are there any recommended acute treatments at the time of an injury, for example?
Yeah, I mean, I'm not the person to ask because I'm not in the clinic, but I think we have to start thinking about this in those early phases. I think we have to start monitoring these athletes for changes. We can see things on functional MRI. We can see something on DTI. We can do something with neuropsychs. We can get an inkling when a player is going the wrong direction. And I think we need to start setting up trials of intervention. Anti-inflammatories, they are checkered past. It's both beneficial, and so it's very tough. But is there a vascular healant? Is there some way to heal this vascular change, lower the amount of breach of the blood-brain barrier? Is there a way to lower the deleterious inflammation? All of these, I think, are important things to pursue in these early individuals, the young individuals, the people that haven't gotten into the proteinopathies yet.
I suspect the answer is perhaps not enough data, but with the advent of new protective equipment, is there any indication that is effective? Maybe it's not, the data isn't fully available.
Yeah, I mean, part of the problem is the skull is like nature's helmet. So you've got a brain that's tethered by the spinal cord, and it has movement inside the skull, and that's what this injury is. It's the rapid acceleration, deceleration, rotation inside the skull. So, helmets may be helpful, certainly helmets that are fixed to the neck where the head doesn't move quickly have been helpful, but those are impractical and anything but NASCAR. And they're coming up with different helmet materials that may slow the blow, soften the, lower the velocity of the hit. So there may be improvements there. But I don't think they're going to be I don't think they're going to be the absolute answer to this. I don't think they're ever going to be able to absolutely suppress the motion of the head going forward, backward, and very importantly, rotating.
Right. Are there any prospective studies underway? I mean, you mentioned, the challenge of having accurate in-life data and cross-referencing that to the.
Yes, there are active studies going forward. We certainly have them at a BU CTE center with something called Diagnose and Detect, which is looking at former athletes, college, NFL. We also have, there are other institutions, San Francisco. I can't even name all of them, where they're starting to bring in young players and look at them. There's the CARE study that looks at former college athletes. So there's a lot being done. This is a disease that develops over time. It's going to take time to really for these studies to bear fruit. So we're all working on the solution with what we have, and looking forward to the next phase, which I think will be treatment. And I am optimistic. I actually think we've made enormous strides in the last 16 years, and if Alzheimer's disease is any indication, with the new therapies, the biomarkers to make a more definitive diagnosis, I think we're on a very, very hopeful trajectory in CTE.
Okay, that's a great optimistic note. Maybe a couple last ones here. We are already a bit over time. Thank you, everyone, very much for your questions. As I said, continue to send them in. We'll share them with Anne afterwards as well. Are there any specific tau biomarkers that distinguish CTE from other tauopathies?
Well, we find different cytokines in the brain. We find different cytokines in the CSF, but those haven't been taken to the clinic, and we haven't seen those. The studies, we're still waiting on the studies that find the differential proteins in the plasma, or that differentiate CTE from something else.
Great. I think probably a question you must get asked a lot. Feel free to not answer it. One is, would you let your kids play football and do this, or contact sports in general? Is this?
I think sports are hugely important. I think team sports are hugely important. I definitely think we need our kids to play these things and stay healthy. Physical exercise is absolutely important to all of our mental and physical health. I wouldn't let my kids play football. I apologize to the football community. There's just too big a risk. Not enough is being done. If those two things change, if they start really addressing the risk of repetitive injury, if they really start making changes to the rules of the game and how these players are monitored, I would consider it. But at this time, no.
All right. That is. Thank you for sharing that. Unfortunately, we are quite a bit over time here. We do have a lot of questions still. I'll send them all along after our talk. Dr. McKee, I really wanted to thank you for sharing all your insights today. It's been a real pleasure having you with
great.
us.
I was happy to be here, and thanks for asking me.
Thanks again. As we conclude the Neurophysiology 2023 series, we'd like to thank all of our partners and sponsors for helping make this diverse and really engaging program possible. And finally, and most importantly, none of this would be possible without our wonderful speakers. And so a huge thank you to all of them for generously sharing their time and exceptional research with us. We really, really appreciate it, and thank you all. In closing, we hope you enjoyed this Inside Scientific series and webinar, and we'll see you again next time.